Today, Community College Oncology, Oncology Nutrition with Ashley Bradshaw, MS, RD, CSO. And if you're not familiar with any of those combinations of letters, we'll talk about those in a little later in the presentation. So, welcome, Ashley. We're so glad to have you here today.
Glad to be here. Thank you for having me.
Absolutely. Well, we're thrilled. Let's find out a little bit more about you. You taught virtual and in-person community cooking classes while in New Bern, North Carolina.
Yes, we had to adapt during COVID, and so
that good for you.
Created the virtual.
Good for you. We all have had to adapt the last few years. That is great. Initiated a grocery program for food insecure cancer patients while in New Bern, North Carolina, and assisted with the growth and development of the nutrition program at the SECU Comprehensive Cancer Center in New Bern.
Yes, learned a lot.
Great. And became a registered dietitian.
Yes.
And what else? What's one thing we should know about you outside of your professional information there?
Yeah, I do have a dog. Her name is Maddie.
Great.
And I really enjoy cooking. That's one of my favorite hobbies. And so I'm experimenting with a little bit more meatless meals lately. So learning a lot in the kitchen there. Good
for you. And does Maddie sample anything?
She tries.
We have a cheesecake lover at home.
Oh,
who likes to counter surf, especially when there's a cheesecake around. So tell us a little bit about your career trajectory. What ultimately interested you in nutrition, and how did you get into this field?
Yeah, so years ago when I was in high school, I actually volunteered at the hospital where I grew up. And they had a volunteer program. And so I was able to work with the dietitians, and I really discovered kind of a passion for nutrition. And so then I went on to Meredith College for a 4-year undergrad degree in nutrition, and then on to Appalachian State University for my master's and my internship.
Great.
And that allowed me to sit for the dietetic exam to become a registered dietitian.
That is terrific. Thank you so much. And we'll maybe go back to that in a little more detail at the end of the presentation. So without further ado, Oncology Nutrition with Ashley Bradshaw, MS, RD, CSO, LDN, and I'll pass the clicker over to you there.
Yes, so thank you all for having me today. I'm very excited to be here to talk about oncology nutrition and why nutrition can be so important in the cancer setting. So to kick things off, we do have a poll question, and this is true or false. Nutrition is not important during cancer treatment. Hopefully you can all get this right. So the answer is false. Nutrition is very important during cancer treatment, and hopefully by the end of the presentation, you will understand why. So we have several learning objectives that we're going to cover today. We want to identify nutrition-related side effects that can occur before, during, and/or after cancer treatment. We also want to explain the importance of nutrition in the setting of cancer. And then lastly, recognize and understand the role of the dietitian in the cancer setting. So to start, I do kind of want to go into a little bit of the different types of cancer treatments. I think it's important to understand what's out there and how they can affect the nutrition status of a patient. So chemotherapy is probably one of the more well-known types of cancer treatments. It can involve a variety of different drugs and agents. It can be given orally or through a PICC line or IV. And patients may come in daily. They may come in weekly, every couple weeks, monthly. Usually if it's a daily type of treatment, they're taking it orally at home. The goal of chemotherapy is to kill the cancer cells, to target them. But unfortunately, in the process, it also harms the healthy cells. It affects both the cancer and the healthy cells. And so that's why we see so many of the side effects with chemotherapy, such as the GI side effects, the nausea, the vomiting, the diarrhea, as well as taste changes and hair loss. Radiation is a little bit more of a specific targeted therapy, and that's going to aim at a certain area of the body to damage the cancer cells in that location. Unfortunately, it also damages the healthy cells as well around that site. And I kind of like to think of radiation like a sunburn. So what's happening on the outside is happening on the inside, and it can be a very sensitive area. And we'll go into some of the side effects that can happen with radiation in a bit and how they can affect nutrition. Radiation is a daily treatment, so patients are coming in usually Monday through Friday to get the treatment, and it's usually over a course of maybe a week or 6 weeks, and it's cumulative. So as they get further into radiation treatment, generally more symptoms start to pop up. Surgery is usually maybe prior or post other treatments, or it might stand alone. But with surgery, we're resecting or removing certain parts of the tumor, and that can cause for the needs to be a little bit higher. So there can be increased protein and calorie needs in a surgery setting. And then immunotherapy is going to try to boost the immune system so the patient can then help fight the disease. And generally with immunotherapies, there's less of the side effects versus chemotherapy. So not as much nutrition concern to worry about there. So with nutrition risk in the cancer setting, with any type of cancer patient, we're generally dealing with an increased calorie and protein demand. And then you compound that with all the symptoms that a patient may experience. It can be very challenging to get adequate nutrition in to meet those higher needs. Some of the symptoms that can affect the appetite or affect the ability to eat can include nausea, vomiting, taste changes, mouth sores, diarrhea, constipation, thick secretions, dry mouth. Those are just a few that may pop up during cancer treatment. And there's also an increased risk for malnutrition, sarcopenia, and cachexia. And we're going to get into those terms in just a little bit. So going back to radiation, this diagram just shows some of the areas that someone can receive, where they can receive radiation, and the side effects that can happen during the course of radiation. You'll notice that no matter where the location is, fatigue tends to pop up with a lot of the symptoms, and that can make it challenging to eat, just from the standpoint of you're tired, you don't maybe want to cook or prepare food, it may take more work to chew the food. That can all influence how much you're able to put in. And then if you're looking at like the head and neck region, if someone's getting radiation up in this location, we're going to be dealing with some side effects, like pain when they swallow, pain when they try to chew, thick secretions. And so that can be some of the symptoms that can affect intake. Versus if we're dealing with the lower regions, like radiation to the colon, we may have diarrhea occurring, electrolyte issues, so dehydration may be a concern. So this just shows some general symptoms that can pop up during the course of radiation. So now to get to those terms, sarcopenia is muscle loss. So that is when a patient loses some of the muscle loss that they have during cancer treatment. It's estimated that up to half of patients with an advanced type of cancer experience sarcopenia, and that's a pretty significant amount of patients. What sarcopenia can cause is it can hurt the patient's survival. It also can cause more side effects to pop up during chemo and make it a little bit more challenging to get through treatment. So we really want to try to prevent, manage sarcopenia when it does pop up. Then we have cachexia, and cachexia is more of a generalized wasting. And generally that is triggered by weight loss, the loss of fat and muscle as well. And it can be caused by decreased protein and calorie intake, or it might be coming from the tumor itself. And this just shows you the trajectory that cachexia can have in a cancer patient. We have pre-cachexia, which is the warning signs, the triggers, before it reaches that cachectic state. And that's when a patient may be experiencing weight loss. They may have anorexia. And it's important to understand that anorexia in the cancer setting does not mean eating disorder. It actually means loss of appetite. A patient can still have an eating disorder in the cancer setting, but generally when we're throwing out the term anorexia, it's they've lost their appetite. And then when we get into the cachectic state, that's when they're having more of a significant weight loss. Their BMI is dropping, they're having that muscle loss, that sarcopenia start to occur, and they're really having trouble getting food in. And then the refractory cachexia is very difficult to manage, very difficult to control. It's an active catabolism, so the needs are very high for the protein and calorie, and it's very difficult to get ahead of that. So with malnutrition, that was the last term there, the scary terms there. It is a form of undernutrition, and this can occur in up to 80% of cancer patients. So that is a very high amount of patients that can be affected with malnutrition. It can negatively impact their quality of life and their treatment outcome. It can also cause prolonged hospital stays or hospitalizations, and that can increase healthcare costs. And it's estimated to be the primary cause of death in upwards of 20% of cancer patients, and that's versus the diagnosis. So that's a pretty significant number as well. And dietitians, we are trained to screen for malnutrition, and I'm going to go into how we do that in just a little bit as well too. So this diagram, this was a study that was conducted several years ago, and it featured 191 patients, and it looked at symptom burden and the risk of malnutrition. And what they found is that as the number of symptoms increase, so when we're getting into 3, 4, 5 symptoms, and those symptoms may include nausea, loss of appetite, but as the symptoms increased, the risk of malnutrition increased significantly. We can see that if we're getting into 5 symptoms, we're dealing with about 80% of patients that are at risk for malnutrition when they get to that many symptoms. Even starting out with 0 symptoms, you can see about a 10% risk of malnutrition. And so to screen for malnutrition, we use the Aspen criteria, which is the Society for Parenteral and Enteral Nutrition. And so we have very specific guidelines that we use to classify someone as malnourished or at risk for malnutrition. We're going to be looking at their weight. We're going to be looking at the percent weight loss. We're also going to be looking at intake, not just short term, but over the past month or more. And then we're going to be looking for signs of fat and muscle loss. And some areas that you may notice some fat and muscle loss might be the temporal region, the orbital region. You might even see some buccal wasting, clavicle. You might see some muscle loss there, as well as when we're getting into the triceps, the arms, and then the legs, the calves, the thighs. If they have their legs showing, we can notice some signs of muscle and fat loss there as well. So we are conducting this screening as part of our nutrition assessment. So our second poll question, can anyone with a cancer diagnosis be at risk for malnutrition even if they do not appear malnourished? And this is a yes or no question, maybe a little bit of a trick question, but hopefully not. So the answer is yes. Just because they may not look malnourished, have the visible signs of fat or muscle loss, they can still be at risk for malnutrition because we still have the criteria of weight loss and decreased intake. So now we're going to switch and look at what's the dietitian's role in the setting of cancer and how can we help. We do a pretty thorough exam when we're with patients. We're going to be looking at their food and nutrition history. So this is going to be doing a food recall. It may be a 24-hour food recall. It may be looking at what they're eating currently versus what they were eating several weeks ago or a month ago. We also want to look at their allergies and see if they have any food intolerances or maybe foods that they're avoiding for cultural reasons. And then we want to next look at their anthropometrics. So this is going to be their height, their weight, their BMI. We're going to be looking for percent weight changes. This is going to kind of give us some of those warning signs of malnutrition as well with that percent weight change. The biochemical data, this is going to be your lab tests, your imaging. This is something that generally we have pretty good access with most of the patients because if they're getting chemo, they're getting routine lab work, but that's not always the case. So we may not have recent or current labs to go off of, but we're going to be looking for more of those nutrition-specific labs. So that may be hydration labs, the kidney function, electrolytes. And it is important to know that certain treatments can throw off some of those labs. There are certain chemos that can cause the magnesium and the potassium to be a little bit lower. So it may not be because they're eating differently. It may be coming from treatment versus what they're taking in. And then with the nutrition-focused physical findings, that's going to be the exam that we conduct on them, where we're looking for those signs of fat or muscle wasting. And then we're also going to be looking at their history. And this is usually something we've done before we come into the visit, where we're looking at their surgical history, their medical history, seeing if there's any comorbidities that we need to be monitoring. An example would be diabetes, or if they've had a history of gastric bypass. Those would be things that would definitely be relevant in the current cancer setting as well. So to assess the nutrient needs of a cancer patient, we do not have direct methods to assess their nutrient needs, so we don't know 100% what their body's burning or needing, but we do have predictive equations that are evidence-based, and we use the Academy of Nutrition's recommendations, and that's the governing organization for all dietitians. So we use their recommendations for the predictive equations. And in general, if a patient is trying to maintain their weight, we're looking at about a 25 to 30 kcal per kilogram. If they're trying to gain weight, we're looking at a 30 to 35 kcal per kilogram. We do have a few other predictive equations that we can use if the patient doesn't fit those molds. And then with protein needs, that can range from 1 to 1.5 grams per kilogram. It may even be as high as 2 grams per kilogram, depending on the state of malnutrition. So the protein can go kind of high in this setting. And then with fluid, we're looking at a 1 ml per kcal. We do have another predictive equation we can use as well. So a lot of it's tweaked and individualized for the patient. We base it off of the predictive equation, but we do customize it for the patient. And then when we get to the interventions, these are going to be very personalized for the patient. We want to make sure that we're meeting them where they're at and that we're taking into account their desire and their willingness. We want to target the symptoms of the treatment. So if they're having diarrhea, if they're having loss of appetite, taste changes, those are the symptoms we want to try to help manage to get them to eat better and improve their nutrition. We also want to give control back to the patient. I think this is a really important part to touch on. Patients don't have a lot of control in the cancer setting with the type of treatment they're getting, how their body reacts to that treatment. And so nutrition and eating is control that the patient can have. And if they're able to help manage their symptoms by what they're putting in, that does give them a little bit of control back. We also want to promote quality of life and advocate for the patient. And this can look different from patient to patient. It may be advocating to their family for them. It may be advocating for them to themselves. It also may be advocating to the healthcare team. We want to help them increase their survival. And then we also want to prevent or decrease the risk for those nasty terms I talked about earlier, the malnutrition, the sarcopenia, the cachexia. We want to definitely prevent that if possible. So when might it be helpful to refer to a dietitian? I like to be brought in earlier rather than later. Sometimes if we're brought in too late, it's almost like putting a Band-Aid. So it's very hard to catch up. So if we can, we want to be involved a lot sooner. I also think it's important for patients to be aware that this is an option they have to meet with a dietitian. It's a service that they can have during their cancer treatment, and it can be a very important one. So when a dietitian can help is if there's any type of weight loss, that would be when to consult the dietitian. Getting ahead of that weight loss sooner versus than later is very important. If they're having any GI symptoms, so this could include nausea, vomiting, constipation, diarrhea, early satiety, fullness, bloating, those would be other reasons to consult the dietitian. And then if we're having oral issues, so taste changes, dry mouth, mouth sores, thick secretions, those could be triggered from maybe radiation or maybe even from certain types of chemos. That would be another reason to consult the dietitian. And then also anorexia, which I mentioned earlier, is loss of appetite. This would be a great reason to bring the dietitian in too, because generally a patient's not going to be eating well when they're having the loss of appetite occur. It's estimated that 15 to 25% of patients present with loss of appetite at the time of diagnosis. and that 26% of patients will struggle with loss of appetite during chemotherapy. Honestly, the majority of patients that I see have loss of appetite. That is one of the main symptoms that tends to come up in this setting from what I've seen. And again, anorexia does not mean eating disorder, and that's a very important distinction to understand in the cancer world. Malabsorption can be another reason to bring the dietitian on board. Maybe a patient has had a GI surgery that's made it a little bit harder to absorb certain nutrients, or maybe treatment is making it a little bit more difficult. And so if there's a risk of malabsorption, that means we're probably not getting the nutrients that we need in to maintain the body and help it fight this process. And then alternate means of high nutrition, this is going to be total parenteral nutrition. That's usually through a PICC line, or enteral nutrition, which could be through a Dubhoff, NG tube, G tube. That would all be, those would be important to bring the dietitian on board so we can make sure they're getting what they need through those alternate means of nutrition. So I thought for the last several slides, it'd be nice to go through some examples of cancer patients, some symptoms they may experience, and then how the dietitian can intervene. So this example, the patient is going through chemotherapy. They present with a 5% weight loss within the past month. They also note decreased appetite, taste changes, and overall fatigue, and they live alone. The diet recall reveals that they are eating less than 50% of their estimated nutrient needs per day. So as the dietitian in this situation, the weight loss is pretty significant there to happen in just a month. And then it's a little worrisome that they're having the decreased appetite and the taste changes. The fatigue can also be a concern, especially with the person living alone. It may make it a little bit harder to prepare meals, to make sure they're cooking meals or microwaving meals, whatever that may look like, but fatigue can definitely influence the ability to fix meals. So for interventions, one recommendation I would have would be small, frequent meals. And it wouldn't just be saying that recommendation, it would actually be looking at the types of foods that the patient could purchase or could keep at home. So we would go through examples together. I would want to base that off of what the patient enjoys and likes to eat, where they grocery shop, want to factor in income level as well. And we want to make sure that the foods are easy to prepare and that they're high calorie and high in protein. Tart beverages, as well as colder and fresher foods, can have a little bit increased taste for the patients. So that can be a way to help with the taste changes. And then a baking soda and saltwater rinse can also be helpful with taste changes. And then we may even talk about some nutritional supplements and shakes like Ensure or Boost, depending on the patient's openness to that. So another example would be a patient going through radiation to the head and neck region. They are halfway through treatment and they're experiencing pain when swallowing, lack of taste, thick secretions, and their intake's estimated to be less than 25% of needs. This would be when we'd really want to talk about nutrition goals with the patient and the healthcare team. Being that they're only halfway through treatment, they still have probably another 3-4 weeks of radiation left. So those symptoms are probably only going to get worse. And then with radiation, it doesn't just end the day that they finish treatment. It doesn't go back to normal. They have about 6 weeks or more of recovery. And so we're looking at several months where the patient is probably still going to have a decreased intake, difficulty eating. The taste is going to still be decreased. The pain when swallowing is still going to be occurring. So we may want to be talking about those alternate means of nutrition. That could be a G tube, a feeding tube. That's something that we'd want to talk about with the patient and the healthcare team and see what their goals are ultimately. Then we'd also want to bring up some oral nutritional shakes and supplements like the Ensure, the Boost, and then look at soft foods with added moisture to make it a little bit easier to chew and swallow the food. And the last example is a patient recently had surgery for pancreatic cancer, and this included a partial gastrectomy, which is a part removal of the stomach, and then a total removal of the pancreas. So altogether, this is known as the Whipple procedure. The patient recently discharged from the hospital and is presenting with weight loss, oily, greasy stools, and decreased appetite and intake. One red flag here would be the Whipple in addition to the oily, greasy stools. That could be a sign that they are malabsorbing fat. And one of the things that a dietitian can help with is the dosing of pancreatic enzymes. Pancreatic enzymes are there to help with fat digestion. And so a dietitian can look at how much fat a patient is actually eating with a meal and then give dosing recommendations for the pancreatic enzymes to the doctor so that it can be really tailored for the meals that the patients are eating. We'd also maybe talk about small frequent meals. Having just had a partial gastrectomy, it's probably a little bit harder to eat the same volume, the same quantity that the patient's been eating. So looking at more of a small frequent meal pattern may be helpful. And then discussing vitamin and mineral needs can also be helpful. They may have some malabsorption going on. And so like fat soluble vitamins may be something we look at, as well as B12, since we've dealt with the stomach being partially removed. But those could be labs that we check for before we recommend repletion. So our last poll question, this is true or false. Dietitians can create customized nutrition interventions for patients to address and help manage cancer-related side effects. And hopefully everybody can get this one right. And the answer is true. That is our job, to help get them through cancer treatment and really reduce the side effects that they're having. And then one last slide here. This is just about post-cancer treatment. Dietitians can still be helpful after patients finish their treatment. We can help with weight maintenance, gain, or loss. Some patients gain weight during cancer treatment. Some patients lose weight. So it may be looking at the goals post-treatment and whether they're wanting to gain that weight back or lose some weight. We want to help them get back to their normalcy with eating, to the foods that they enjoy, that they love, and the patterns that they like with eating. And then we also may be providing some diet education on survivorship and cancer prevention to help prevent reoccurrence. The American Institute for Cancer Research has some really great guidelines on diet and cancer prevention. And so we do have the diet education survivorships with patients where we talk about eating whole grains, lean protein, and enjoying those fruits and vegetables. So that wraps it up for me. Thank you.
Great. Ashley, thank you so much. This has been fascinating. I really appreciate it. Let's see, before we go ahead and close, let me ask you, so if a student is watching this and saying, hey, that looks pretty interesting to me, tell us a little bit more about the different degrees you have, and if a community college student is interested in pursuing a career in nutrition, and maybe specifically with an eye towards oncology, what that student would need to do.
Yeah, that's a great question. So generally, they'd have to have some type of undergrad degree in nutrition. That may be a 4-year undergrad degree or post-bac if they're coming for a different degree, or they went for a different degree first. And then they would need to get their master's. They do require now that all dietitians have their master's in nutrition. And then there's a internship for a year where you get good experience in clinical, food service, as well as community. And that prepares you for the registered dietitian exam. And that's a board certified exam. And then for the CSO, that is an oncology specific credential that I have. And that's board certified specialist in oncology nutrition. And that requires that you're a dietitian for at least 2 years and that you have 2,000 practice hours in the oncology setting, and that you sit for the exam. And we have to take it every 5 years. So it's a little bit more upkeep there with that one.
Yeah.
So you really want to be sure that you want to go into oncology before you sit for that exam. But there's a lot of areas in the nutrition setting that people can go. It's not just oncology. There's diabetes, renal, and then separate from clinical, there's food service. So there's just a ton of areas for dietitians.
Great. That's impressive. Well, thank you so much for sharing that with our audience. And let me close with, I can tell you really enjoy what you do.
Yes.
Can you mention to our audience maybe 1 or 2 of the things that you find most rewarding about your work?
Yeah. Working with cancer patients is definitely a tough field, but they are some of the most amazing and giving and just, they really are some of the most amazing people I've ever worked with. And getting to be with them throughout the journey is what I enjoy. I used to work inpatient, and you get to see a snapshot of they come into the hospital, they're really sick, they go home, you don't know how they did, how they're doing.
Right.
And so in the outpatient setting, you really get to be with them throughout the whole cancer journey, whatever that may look like, but
Sure.
you get to support them as best as you can.
Sure.
They become like family. And so it's building those relationships that I really enjoy.
That makes a lot of sense. All right. Well, thank
Yeah,
you
thank
so
you.
much. Yeah.
It's great to be here.
Oh, we loved having you. Really appreciate it. Let's see. I want to thank the state of North Carolina University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, the North Carolina Community College System. We want to thank the people of the UNC Lineberger Cancer Network, including Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh for all of their hard work on this and every one of their lectures.